Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about cancer. Several months ago, I began a series on cancer, and I'm going to continue to talk about this subject in this segment. This segment is going to be specifically dedicated to cancer of the esophagus. And this big book that I wrote last year, ouch, The Art and Practice of Modern Clinical Medicine, 136 chapters, and chapter 10 is, of course, on cancer. And this is where I get this material from that I'm going to use today to talk about cancer of the esophagus. According to the American Cancer Society, this year, 16,940 individuals will develop cancer of the esophagus. And of that number, 15,690 will die of cancer of the esophagus, which is a very, very, very bad statistic. As far as worldwide is concerned, it is expected that 480 to 300 folks will develop cancer of the esophagus, and that is 482,300 folks will develop cancer of the esophagus, and 406,800 people are expected to die of cancer of the esophagus. As you can see, very few people survive this particular cancer. It's a very, very bad cancer. Now, the risk factors, of course, well, first of all, you have to understand cancer of the esophagus is 50% more common in blacks as compared to white. It is not quite sure why that is. And there are many risk factors for cancer of the esophagus. The most common risk factors are alcohol abuse, tobacco smoking, and other risk factors include Barrett esophagus, alkalasia, Plumber-Vincent syndrome, celiac disease, consumption of too much red meat, HPV infection, especially HPV types 16 and 18, lye strictures of the esophagus, that if somebody happened to be damaged by drinking lye or somehow lye found its way in their throats. As far as symptoms are concerned, of course, a lot of times people have symptoms when it's too late, but the most common symptoms are difficulty swallowing, upper stomach pain, chest pain, anemia, weight loss, etc. Now, as you can well imagine, the esophagus is a very, very important organ. That is the organ, first of all, the GI tract began in the mouth, and as we chew the food, it goes down the throat, it goes right down the esophagus. This is a big tube that then takes the food or water, whatever it is we're drinking or eating, into the stomach. Now, one of the main reasons why cancer of the esophagus occurs is because of the irritation from the alcohol, because alcohol abuse, there's a tremendous amount of irritation that occurs in the esophagus, a condition we call esophagitis. And then once you have this irritation, then you have inflammation. Everywhere, every time you have inflammation or chronic infection anywhere in the body, the cells that are in that particular organ become dysplastic. Dysplasia is the first abnormal step in the normal cell becoming abnormal. And that's when the DNA begin to get damaged. And those cells are the cells that can go on to develop, to become cancerous. Tobacco smoking is a very nasty, a very bad habit. Forget about all the situation involving, you can't forget about them, but put that aside for now in terms of the addiction and so on. But it is really, really very toxic to the human tissue. It is amazing. I have a chapter here on smoking. A tremendous amount of poisonous material that tobacco contains. Again, it's a free enterprise system. People are allowed to sell the product. It is up to the public to at least be aware how bad the product really is, and they can use their own judgment as to whether they should or should not use it. It is not my job to be here and tell people what to do. Suffice it to say, those things in combination really is the number one reason why people develop cancer of the esophagus. The other risk factors, I've mentioned them to you. And in particular, they talk about diet. That's very, very important as well. It's not just the red meat. It's also in countries where folks have a habit of using the meat on the open fire, on the carbonic material, the dark material that's on the star, all that stuff. In these particular countries, they have the highest incidence of cancer of the upper GI tract, in particular stomach, and cancer of the esophagus. So one has to understand that. It's very, very common. Now, when you start having these symptoms, as I said before, one of the first key, I mentioned anemia, but you got to understand. Let me take a moment and explain to you what I mean by anemia. Way before anemia would develop in someone who is developing cancer of the esophagus, the first thing that you have to be aware of, you have to understand iron kinetics. What I mean by iron kinetics is the fact that there are a variety of things that can cause one to develop low ferritin, i.e. you're bleeding very slowly. But that would be the first indicator that something is going on somewhere in the GI tract, and of course the esophagus is part of the GI tract. In a man, the normal ferritin is a range from 10 through 320. In a woman, it's a range to about 290. So therefore, if you're practicing medicine and you make it your business to always do serum ferritin in your patient 2, 3, 4 times per year, then you will begin to notice that the ferritin is going down. The ferritin is a storage ion. It's part of the storage ion. A normal sized man, such as myself, is expected to have 1.5 grams in the storage iron. That's 6 units of blood, and 2 grams in the circulation. That is 8 units of blood. So therefore, you will have to deplete the entire storage iron, all of it, before anemia starts setting in. In this book, I describe the different steps that involve in the development of anemia. It's very sophisticated, but it's fascinating hematological thing. So therefore, if you understand hematology, you understand iron kinetics, as you see your patient's ferritin start going down, that's the time for you to step in to have the patient seen by a gastroenterologist to find out what is going on. Why is the patient iron going down? In both men and women. In women, it's a little bit more complicated. It's a little more complicated because women lose blood during childbirth, they lose blood during menstruation, but there is a formula, clinical formula, one can use to take that into consideration to determine why is, even though the woman is menstruating, why is the ferritin at this and that level. Let me give you an idea of what I'm talking about in terms of childbirth. For every pregnancy that a woman carries through between 8 months and 9 months, full birth between 8 months and 8 months to 9 months, that woman loses 750 milligrams of iron. Let me repeat that. For every pregnancy that a woman carries to complete the birth process between 8 months and 9 months, she by necessity must lose, that is a normal pregnancy now, she must lose 750 milligrams of iron. Now you say, where did that iron go to? The fetus. The fetus sucked up that iron from the mother. You understand that? Okay, so therefore, you have to take that into consideration, how many times the woman was pregnant, how many times she carried to birth, to full pregnancy, how many children she has had, and then how young was she when she began menstruate, and how is the quality of the menstruation every month. Those are crucial things that you have to take into consideration to practice clinical medicine properly. When you take that into consideration, you can, and we do, those of us who really completely understand this stuff, able to pick up when the iron loss is more than it should have been, in spite of the fact that, because a normal menstrual period is 50 cc's of blood per month. Unless there is some menstrual irregularity, it's 50 cc's of blood. Okay? You have to understand, each cc's of blood has 0.5 milligram of iron in it. By knowing this formula, you know what to do with it. You learn it. Somebody has taken the time to teach it to you. You're able to calculate backward and save somebody's life by stepping in very early in the process. You don't have to be a genius to figure out that somebody is anemic. They're anemic. Big deal. It's important, but they're already anemic. So you're going to step in. By the time you step in, that the patient is already full-blown anemic. It has taken several years of he or she losing blood slowly. By the time you step in, the cancer is already stage 3. But if you understand iron kinetics, listen, I'm not here to sound as I'm being arrogant. I am somebody who teaches that stuff. I understand it. I make it my business to understand it. So therefore, you could step in way ahead of the time. By the time she is basically, and then there's something else I can tell you. When we send the blood through the laboratory, I'm taking time to explain this to you because it's really fascinating. When you take the tube of blood, you send it to the laboratory. It goes through the computerized system in the laboratory nowadays. There's a number called RDW, red cell distribution width. Believe it or not, there are many things that can cause your RDW to become abnormal. I'm not talking about that. I'm just specifically talking about iron deficiency. Iron deficiency is not the same as iron deficiency anemia. You iron deficient way before you become, months, years, 2, 3, 4 years before you become iron deficiency anemic. So therefore, the very first test, this is fascinating, the very first test that you're going to get back from the laboratory that becomes abnormal when you're iron deficient is the RDW. Why? Because as you're losing blood very slowly, you're losing storage iron together with that very slowly. You have different sizes of red blood cell in your circulation because you have red cell that has different concentration of iron. How about that? That's how the RDW becomes the first thing, the very first thing that becomes abnormal before the ferritin become obviously abnormal. You understand that? So if you put that in your back pocket and you understand it, you're able to rule out all other things from the top of your head that can cause the RDW to become elevated. I'm not going to sit there and enumerate them for you. You want to read about this stuff, there's a whole chapter in this book about iron deficiency. Believe me, it is thorough and it is complete. All the stuff that I'm discussing with you is completely, thoroughly described in this book. I know folks don't want to touch the book. That's their problem. They're going to remain ignorant of those facts. They're not ignorant individual, but they're going to be ignorant of these facts. Okay? So, and this is not for the sake of being to practice pretty medicine. It's for the sake of the benefit of your patients. I couldn't care less what you think or feel about me. I frankly couldn't care less. But I do care, however, when patients are not getting the care they should get. Because when someone comes to your office, you agree to take care of them. That's a commitment like no others. Because that patient has every right, he or she, to expect nothing but the best from you. And I couldn't care less who you are, what accent you talk with, what color of your skin. This is medicine. This is God that tells somebody you know it better than the other person. You go and talk to God. Talk to God about it. You don't like the way I speak, that's your problem. Talk to God. Talk to God. You don't like the color of my skin? Talk to God about it. Why? What do I care? What I care is the fact that the knowledge is there. Knowledge is power. So, if someone has cancer of the esophagus, which is a very difficult cancer to treat, that's why I'm taking the time to explain. Very difficult, and the best of hand It's very difficult. But however, your absolute best chance, if you were to pick up the abnormality in the esophagus, that will ultimately develop into cancer. Every cancer starts somewhere, somehow. But as the cancer is developing, you are losing blood very slowly, unknown to you. You can't see that blood. It is mixed with the stool. Let me give you the formula. It takes more than 25 cc's of blood and up to make the stool become positive when we physicians test it, looking for occult blood. Let me repeat that. A minimum of 25 cc's of blood must have been mixed with the stool in order for us, when we test it with that little gadget that we use to test for the occult, for it to become positive. You have to know these things. If you don't know these things, then that's your problem. Then you should refer the patient to someone who knows these things. Or he or she wants to get involved, he or she will get involved. No, you could way back, I'm talking 2, 3 years, you could have picked up that something is wrong. Not because the patient has pain or symptom of any kind. I'm serious. That's when you find that something is wrong with the serum ferritin. Every single week, every single month in my practice, I have strong men and women working, minding their own business, and suddenly I say to them, you know what? Things are not as good as you think it is because your ferritin is dropping. It's a range. I don't like that. 100% of the time, 100% of the time, the gastroenterologist is going to find something either in the esophagus, something either in the stomach, something either in the small bowel, something either in the large bowel, or in the rectum, to explain what I said. 100% of the time. Not 99%, 100% of the time. As soon as I refer that patient, he or she is going to find it. And you would have saved somebody's life by doing something simple. Not multi-million-dollar machine, but the biggest machine and the most expensive machine of all is the brain. That's the gift that God gave us. So therefore, if you wait until your patient showed up with cancer of the esophagus, that's been seeing you regularly, that doesn't always happen. Sometimes people don't come to us, and they come too late, in particular black folks. That's probably why I say cancer of the esophagus is 50% more common in blacks than in white, because black folks take longer time to go to the doctor for a variety of reasons. They're less well insured, they have less money, they're busy working 2, 3 jobs, so on and so forth. That happened to white folks as well, but more so to black folks, because frankly and honestly, black folks in this country are poorer than white folks. That's the reality of it. And poverty, this articles happened a few months ago, made it clear. The poorer you are, the earlier you die, and the more you suffer. The articles prove that. This is not just me pontificating. Go online and check it out. So work hard, go to school, learn stuff that's going to enable you to earn the necessary money so that you could provide the best medical care. You could find somebody to provide it for you. That's just the reality of it. And you're talking to someone, I was, believe it or not, one of the poorest little boy God has ever created. But I work hard. I work very hard to get where I am. Those who are puffing and huffing about, I'm not asking for the acceptance. I couldn't care less. All I want is inclusion because I earned my inclusion. That's right. Acceptance, forget about it. What do I care? So therefore, the point to be made is the fact that if you have cancer of the esophagus, it didn't happen yesterday. It happened 2, 3 years ago. It's just you just did not know. By the time you start having symptoms of difficulty swallowing, it means the mass is too big. It's causing the narrowing of the esophagus. By the time you're having upper abdominal pain, it means that the cancer is already so big, it's pressing on structure that's causing you pain. By the time you're having chest pain, the same thing. By the time you're becoming anemic, you know how long it takes for you to become anemic? I just finished telling you. To become anemic, you would have already lost the equivalent of 6 units of blood in a man or the equivalent of 4 units of blood in a female. Because each unit of blood is 250 milligrams of iron. I'm giving you all these numbers. I hope you remember them. Each unit of blood has 250 milligrams of iron in it. So if you lose a gram, that's 4 units of blood. That's 4 bags of blood. When you go to donate blood, that big bag, that's 4 bags of that. So, and a woman is 4 bags she would have lost by the time she becomes anemic. The minimum, by the way. And a man is 6 bags. Now, wait a minute. It's more. Why is it more? Because you're anemic. For you to become anemic, you are now using the iron in the circulation. That's it. You're finished with the storage iron. That's finished. Finito. You are now using the iron in the circulation. And the man, he's using the 2 grams that's in the circulation. And the woman, she's using the 1.5 grams that's in the circulation. Okay? Now, it depends at what point the anemia is picked up. If by the time she shows up, or he shows up very pale, shortness of breath, having headache, having chest pain, having trouble walking, having trouble breathing, well, the anemia is really far advanced. So you already have to put that into equation as well. So who knows? It depends when he or she presents. So when the blood count was done. So anemia is an advanced stage of the disease. That's the point I'm trying to make. It's an advanced stage of the cancer anywhere in the GI tract. And it is not necessary for that to happen. As long as the patient sees you regularly and the patient listens to what you're saying and you're doing the blood count, you know how to do a serum ferritin. I know that ferritin is a phase 2 reacting protein. Yes, nobody knows that better than I do. So if you are concerned about the accuracy of the serum ferritin, namely, does the patient have other diseases such as rheumatoid arthritis, such as scleroderma, or God knows what, or Crohn, or this and that, all these other stuff, so that can cause the ferritin to be falsely elevated. Guess what? Let me give you something to put in your back pocket, because obviously I'm in a good mood of teaching today. To double check on the accuracy of the ferritin, what do? You do a sed rate. That's right. You do a sed rate because if the sed rate is elevated, then the ferritin may be falsely elevated as well, because the sed rate can only react in a positive way because there's a substance in it. Are you ready to write this down? Are you ready? Because the point I'm making is the fact that in order for the sed rate to react, you have to have a phase 2 reacting process going in as well. That's the fibrinogen. The sed rate will not react unless the person has sufficient amount of fibrinogen, because fibrinogen is a phase 2 reactant protein. If you have low or no fibrinogen, and such conditions and costs do exist, your sed rate will not react. And there are at least half a dozen or more things that I will not discuss with you that can cause the sed rate not to react. But if your ferritin is high, and your sed rate is high, you got more work to do. I won't tell you what it is, because I can tell you everything I know, but there are more work to do to figure out if the ferritin is in fact what is represent what it's supposed to represent. But suffice it to say, the best thing you could do to answer that upward question is the ferritin high, then the sed rate must also be high. If the sed rate is normal, the normal sed rate is from 0 to about 20 something, and if it comes back normal, then you can interpret the ferritin properly, because you can't have one without the other. If the ferritin is falsely elevated, the sed rate would also be high. You understand that? So I'm giving you something to put in your back pocket. It is super important. I hope you understand. I'm talking about to my colleagues right now, those who are in the business of practicing medicine. Okay? They think they know everything, and some of them are absolutely flat out brilliant. But, you know, for every brilliant person you find somebody else who's much more brilliant. I know that for a fact. Believe me. Okay, so what I'm saying to you is the fact that you have to know things. You have to know things. Clinical medicine is extremely complex, extremely complicated, but it's a fascinating field. Fascinating field. I mean, it's an art like no other, as far as I'm concerned. If you commit yourself to knowing it the way you're supposed to know it. So therefore, cancer of the esophagus can be picked up early if you do a serum ferritin. And if you do a blood count, the IDW will become elevated. There are several other things that can cause the IDW to become high. I'm not going to bore you with them because that's none of your business. Those are stuff that I'm going to take to my grave with me. However, if you know how to interpret it at a glance, at the bedside, at a glance, because right away, oh my God, the IDW is high, then you are required to evaluate that. I once diagnosed a guy with cancer of the stomach. His hematocrit was 52%. 52%. But his ferritin was 12, right here at the hospital up the street. We found a huge cancer in the wall of his stomach. And this is one of 2 patients in my life, in my career, whose life I have saved with this nasty cancer of the stomach. This was a complete physical exam, no symptom at all. 250-pound man, 6'4", construction worker. His hematocrit was 52%, but his ferritin was 12, and the normal is 320. What more do I need to tell you? Those were the days we didn't have endoscopy. I ordered an upper GI series as my first test. There was this huge fungating mass in the wall of his stomach. Every now and again, I see him walking around town in the city of White Plains. He's alive, some 30 years later. Listen, I'm going to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.